the definition of the face? The face definition is the region between the hair, on the side the two ears, and on the bottom by the superior part of the neck. Usually it's very difficult to explore face, especially in second trimester. This is why I just said that Azim have shown us a lot of nice images in first trimester, because I think that in first trimester it's easy to turn around the baby than in second trimester. Very quickly, just to tell you in embryology, that the face is complete at 7 weeks. At 7 weeks you can here see the narrows and the upper clip, and you see here that you can have here cleft, medial cleft, and lateral cleft. As always in ultrasound, you have 3 space planes. Always think 3 planes. Frontal plan, the frontal plan we can explore the lips and the nostrils. This is what we ask in the French college. The eyes with the intraorbital diameter and the crystalline, and you can see the palpebral slot, the eyelash and the eyebrows. The sagittal and the parasagittal plan will permit you to see the profile, the nasal bone, the palate, and on the parasagittal you can see the ears. We can also use the multi-slice view, especially when you suspect a problem with the nasal bone, absence of nasal bone. And you can do reconstruction, especially if you have to explore the palate, the velar palate or the posterior palate. This is usually what you have to show every time that you explore face. The frontal plan, the sagittal plan, the parasagittal plan on the right and on the left, and the axial plan seeing the intra-orbital diameter. On normal face in 3D and 2D, you can see here the eyes, the nose, and the mouth. It may be difficulty because if you have little amniotic fluid, it's always difficult to explore in 3D. The difference between the 3D and the 4D is that the 3D will give you better images, but you have to have a very good condition of exam. For example, you see here, they sent me this on saying that it's a cleft lip, lips. In fact, it was an artifact. It was the code. So be careful when you use the 3D, and especially also, this is the real-time 3D. It's better to see the movement of the baby, but you have several times this kind of image. You have to change the gain, and to have better image like this one, to take off the gain, so like this you can see the face better. The 3D sometimes have this image. This image is not a malformation, it's just baby who have moved while you are taking the volume. Now you have this kind of image. You can have surfacing, and at the same time you can have the profile on the left and on the right on the same image on the same volume. The X-ray will help you a lot, especially in nasal bone. When you suspect an absence nasal bone, you can do an X-ray bone, and you can see here that the nasal bone are present. Just taking this volume and you see this, and it is normal. So let us see some pathology. The cleft lip, as you can see, this is a unilateral cleft. This is a medial, always very bad prognosis, and this is a bilateral. This is a normal image. The surfacing here will help you a lot to explain to the parents what's mean a cleft lip. So you can just have a little one, a big one, a bilateral, a middle one, bilateral, a little one. So when you have a cleft lip, you have always to have family histories to see if the patient is taking drugs, especially Lipakin for anti-epileptic. 50% of cleft lips are associated with the cleft palate, and it's not the same prognosis and it's not the same operation, and you have to explain to the surgeon if there is or not a cleft palate. If you have a bilateral cleft lip, you have 75 to 90% of cleft palate, so you have to search for it. If you have a medial cleft, it's always a malformation. It's not an accident, and you have to search for oroplosencephaly to explore midline on the brain and also on the heart and on the abdomen. So you have to search for other anomalies as every time, like Azim explained to you, because you have a lot of chromosomal aberration with a cleft lip, especially trisomy 13 and trisomy 18. And it's always to see what's behind the lips. So the maxilla is very important for the surgeon. This is the normal maxilla. You take 10 millimeters from the teeth here. At 22 weeks or at 32, it's the same thing. And you have a line from here to here, and you measure the line, it will be 23 millimeters, plus minus 2.6 at 22 weeks, and 29 millimeters plus and minus 2.5 at 32 weeks. If it is more, it means that you have a maxilla problem. Look, I will show you. This is a normal maxilla. If I measure from here to here 10 millimeters, and I draw a line from here to here, it will be about 24 millimeters. If I take a line from here and I draw 10 millimeters, you see that here is more large because you have an alveolar cleft. So it's very important for a surgeon to explain to him if it is isolated cleft or if you have also an alveolar cleft. You see here the rupture of the maxilla. The bone palate, it's a little bit difficult. You can see it in the profile, in the sagittal plant. You see here the corpus callosum, the vermis, and you can see here the palate. You turn 90 degrees and new machine can turn for you. You see here the bone palate, and you see it's complete just behind the tongue. So for sure here there is no cleft palate. Here, this is normal. And look here, these images. You can see here, there's a palate, a cleft here, because you don't have continuity at the palate between, just behind the tongue. Here, you can see it's double. There is discontinuity. You see, in video, it's open, and there is a cleft palate. For surgeon, it's very important to show him this. You can use the multi-slice mode. You have a volume, and then you cut several times, and you can see if here the palate is normal or not normal. And even you can do the 3D render. It means that you have the volume, and you can move here the posterior view like this. You can see here the palate. You see here. So you are sure it is normal. You see. You can take this volume and you work on it on the evenings to be sure if there is a cleft palate or not. So we'll go a little bit. The interest of the Doppler is less and less because it's really very, very difficult to appreciate the Doppler, so I will not speak about it. I will speak just about tongue because Azim showed you that you have the retrogradism. And this is an emergency after delivery. This is not important. I just want to show you the tongue by sagittal plan. On the sagittal plan, you can measure the frontal nasal angle. Normally, is 130 degrees. You take here the profile. You have the palate, and you can measure. It's measuring immediately by a new machine. You have just to put to the angle and it will measure you and it gives you, you see here, 131. If it is more than 145, it means it's an open angle, especially for trisomy 21. And if it is less than 90 degrees, it's other malformation, especially for genetic malformations. will not see this angle because we have a lot of image to show. So, you see here, the hypoplasia of nasal bone, it's not mean that the nasal bone are not here. It just means that there is no ossification of nasal bone. You see the nasal bone are here, but you see them that they are hypoechogenic. We speak about hypoplasia of nasal bone, we have to speak about absence of ossification of nasal bone. And this is very important. As Azim explained to you, if you have an hypoplasia of nasal bone or non-ossification, you multiply the risk of trisomy 21 by 67. 67 more risk to have trisomy 21 if you have hypoplasia of nasal bone. It means that if you have a woman with 1 on 2,000 risk of trisomy 21 in first trimester and you have absence of nasal bone, you multiply by 67 the risk for her to have trisomy 21. So here you see there is no ossification, and you can use, as I show you, the bone, the nasal for the 3D X-ray. You see this is normal. You can see nasal bone here, and you see here there is no nasal bone. There is no bridge between the two sides of the midline. See, this is normal. This is abnormal. And you can see multi-slides view like this. You can be exactly on the sagittal view. You are not on parasagittal view on the left or on the right. Here, for example, you see that the corpus callosum is here, and you are sure there is no nasal bone on the same plane. Okay? This is a Bender syndrome. It's not very important with the associated sign. What is important, this is the micrognathia as I show you. Here you see there is a micrognathia. And what is important to see, how is the tongue? Because it's an emergency after all, as I told you, and I want just to show you a video like of this. You see here the tongue, but if we can see the video, I hope. Yes, we can see the video. Look here, you have sagittal front, and you have here the tongue, and you see that the tongue is going, you will see her better, the tongue is going in the nose. Look, you see, this is the extreme of the tongue, and instead of being here, you see it's going up in the nose. You see here? So this is an emergency after delivery because he cannot breathe. Okay? So we'll continue very quickly because we have not a lot of time. To speak about ears, as Azim told you, this is also, you can take a volume, take the ear in surfacing, and then take off the surfacing and put, instead of the surfacing, X-ray. When you put X-ray, you can see here the suture. So you put a mark on the suture and you return to the surfacing. Like this, you can see if the ear is low setting or not. You understand? You have the volume, you show the surfacing. The surfacing, you see the ear. You pass to the bone X-ray in 3D. You see the suture. You say that the suture is here. If the ear is lower, we can say that it is a low set ear. Okay? We'll continue in golden ear. You see the golden eye. It's asymmetric malformation of the ear. You have from one side it's a little bit normal, other side it's really very abnormal. This is a golden eye sign. The charge is an association. This is a baby I see 6 months ago. I have a cleft lip here. I say to the patient, it's not very important. And I was looking, I see here in nasal bone the problem, and I look, especially here, look, you see here, this is the tongue, and you see here, that there is a cleft here, palate. You see there is discontinuing in this palate. So I say, okay, it's more than normal. So I look on the eyes, and you see there is asymmetry between eyes. And they look at this eye, and they see that there is a problem here. So I see it, and it was a glaucoma. So I searched about CHD gene, it's mean the gene of Charge syndrome, and this baby has a Charge association syndrome. So the prognosis is very poor, and we have done a termination pregnancy. You see the eye with the glaucoma. Usually we say left lip it's okay, but when we have this, the prognosis is really more poor. Now, just to finish, just to speak about eye anatomy, really eye is more and more easy to explore. As you see here, we can see all the structure of the eye. We can just measure the IUD. We can look at the eyes at 12 weeks. We can measure the IUD medial, external, or internal. Anyway, use whatever you want, but usually you can put an eye between the two eyes, as you see here. You can see the gradient. I have 5 more minutes. Okay. This is the trisomy 21. You see that the angle is open, just with the gradient of the eye. This is eosinophils. It was a Cornelia de Lange syndrome. So, the biometry of the eye is very easy. At 22 weeks, you have to measure it between 10 and 12 millimeters, the diameter, and at 32 weeks, it's more than 15 millimeters. So you see here that you can put more than one eye between the two eyes. Here you can put at least 3 eyes, and especially also you have microphthalmia. It was a trisomy 13. So this is what you have to learn. 22, 10 millimeters, 32, 15 millimeters. You can measure it from here to here or from here to here. It is a cycle. It's always 10 millimeters at 22 weeks. It's easy to learn. So you can see here there is microphthalmia on the left. This is a microphthalmia. This is a normal one. This is a normal eye. This is a microphthalmia, unilateral microphthalmia here. Here I show you bilateral microphthalmia at 13 weeks. This is epiphtalmia. It's been a macrophthalmia. As you see here, it's more than 15 millimeters at 22 weeks. This is images from Rabia Shawi. This is images from Bani Rabia. You see there is epiphtalmia, but also you see there is a cataract here. So you have to see what's happening after. It's means that they have malformation of the brain. This is an anophthalmia. You have no eye here. You have no eye here.
Only 2
minutes, okay. You see here also anophthalmia. This is catastrophic. It's bilateral anophthalmia. There is no eyes. To say there is an eye, you have to see the eyes, not to see the orbits. Okay? This is an anterior cyst of the eye. You see here, you have the cyst here. It was this baby after, and he has been operated, no problem. So, because we have just little time, you can see here cataract. You see here cataract, cataract, cataract. If it is isolated, and especially if there is a family cataract, there is no problem. But it's not isolated, you have certainly a genetic syndrome you have to see. This is the persistence of fetal vascularization. You see here, when you see here detachment, décollement of the retina, this is the Yenudian artery, and this is a detachment. You are sure 100% there is a brain malformation when you have this. Sure 100%. You cannot have this without a malformation in the brain. You see, this was a malformation for another okay. This was a valgus valgus malformation. This is a colorectal in toxoplasma. You see, everything was white. This is also an image of Shelby. Colorectal cyst I'll show you. This is another one. You can use the 3D to see, as I show you for Charge syndrome. Dacryocystosis is very frequent. There is no complication usually, just 1% of complication, but it's always better to see it before delivery. And I think I will stop here to have more questions. Just to see this, usually you see the face, and after you see this, and patient say, oh, my baby had a very nice face. En fait, c'est l'abdomen. Merci.